presentation offers a brief overview of intradural extramedullary spinal cord tumors. Spinal tumors can be broadly considered in three groups. We have extradural tumors, that is outside the dura. We have intradural tumors, which are either intradural and extramedullary or intradural and intramedullary. Extradural tumors are mostly tumors arising from the bone. The commonest of these tumors are the secondaries from the breast, from the thyroid, from the lungs, very often from the prostate, very often metastasize to the spine. Intradural extramedullary tumors may be schwannomas, meningiomas, rarely neurofibromas, or others. Intramedullary spinal cord tumors include ependymomas, astrocytomas, and rarely hemangioblastomas. Tuberculomas have also been detected intramedullary. The two commonest IDEMs, or intradural extramedullary tumors, are schwannomas and meningiomas. 90% of schwannomas are sporadic, 10% will be associated with certain syndromes like neurofibromatosis. Clinically, an IDEM would present with myelopathy if the dorsal or cervical cord is involved. Initial presentation may be with a brown sequard where there is ipsilateral corticospinal and posterior column involvement and contralateral spinothalamic tract involvement. Paraparesis and quadriparesis are more common clinical features. Chorda equina will be involved in IDEMs below the level of D12. Sometimes in chorda equina involvement, you might have radiculopathy with one nerve particularly weak. This is even more common in schwannomas of the dumbbell variety, where the tumor extends into the neural foramen. Meningiomas also produce symptoms of cord compression. A third variety of extramedullary intradural tumor is ependymomas. Ependymoma is classically an intramedullary tumor, but a myxopapillary variant usually arises from the filum terminale and can fill the lumbar spinal canal. Other intradural extramedullary mass lesions include drop metastasis. In children, medulloblastoma metastases are common. In adult, glioblastoma metastasis dropping into the spinal canal, producing an IDEM, has been recorded. Diagnosis of an IDEM usually requires a magnetic resonance image. Schwannomas are seen as oval-shaped lesions. They can displace the cord, the spinal cord, if it's in the dorsal region, or it might displace the chorda roots in the lumbar region. Some schwannomas may be dumbbell-shaped, that is extending from the canal through the neural foramen. Meningiomas are also oblong, but they have a dural base, and classically they may have a dural tail. This sign is not always seen. Ependymomas, the myxopapillary variant, usually starts from the corners and extends into the lumbar spine. X-rays and CTs may show scalloping of the vertebra in long-standing spinal tumors. Preferred or in fact the only modality of treatment for a schwannoma or a meningioma is surgical. The approach is usually through a laminectomy. So in some small tumors, a hemilaminectomy exposure may suffice. Localization of the skin muscle exposure is usually decided under CR. Once laminectomy is done, the dural opening can be tailored using an intraoperative ultrasound. Not often done, but it is possible. When you have a focused exposure, the dural opening is made just above the lesion. The next step after opening the dura is defining the tumor and resecting the tumor. Arachnoid is stripped off the tumor, and nerve roots which are attached, which are adherent to the capsule of the tumor are stripped away. This is usually followed by some intratumoral decompression to decrease the volume of the lesion so that it is easier to separate it from nerve roots. In case of a meningioma, the base is coagulated and then the dural attachment is cut. In schwannomas, very often, one or two nerve fibrils may need to be transected to remove the tumor in toto. Dural closure after removal of the tumor usually is done under the microscope with continuous 5O proline sutures. To summarize, schwannomas and meningiomas are the commonest IDEMs. Presentation can be with backache or with myelopathy or radiculopathy features. Imaging with MRI usually shows an oblong lesion displacing the cord or the chorda roots. The treatment is surgery. Intraoperatively, care is taken to protect the spinal cord and the roots. The principle is to save as many rootlets as possible. Whatever roots can be dissected away from the tumor should be freed. Intratumoral decompression is recommended. The reduction in volume of the tumor facilitates its delivery and facilitates dissection of attached nerves and the spinal cord. In meningiomas, coagulation of the dural base provides a Simpson grade 2 resection. Dural closure is done under a microscope to prevent CSF leaks and sometimes reinforcement with fibrin glue, with fat overlay, or with special adhesive material is used to prevent the CSF leak.